everyone. I'm Dellann Elliott Mydland, President and CEO of the End Brain Cancer Initiative. And our mission is to help patients with disease in the brain, with cancer in the brain and the central nervous system to receive the best care possible and to educate them about the necessities of considering a clinical trial and advanced diagnostics as part of their treatment options. And today I have the pleasure of getting to spend some time with Dr. Christian Grommes. He is a specialist in the disease known as PCNSL. And I want to tell you a little bit about him before he gets to talk, okay? He is a neuro-oncologist, an early drug development specialist at MSK in New York. I looked at his resume and you incredible work you are doing, incredible accomplishments, and your research and your publications from that research are vast. And I just want to say thank you to you because
thanks.
Truly, you really have dedicated your life to research and to this disease as well. So thank you. His areas of expertise are primary brain tumors, CNS lymphoma, central nervous system lymphoma, and brain metastases. We are so delighted to have you today, Dr. Grommes. We need more people, special people like you. Thank you. I also want to thank Curis Therapeutics for bringing us together, for investing in the disease of PCNSL and into this research, and for helping you and I and the End Brain Cancer Initiative with this educational video for patients and the PCNSL community and the distribution, which will be global, helping us with this project. So thank you, Curis Therapeutics. What is the basic definition of PCNSL?
So PCNSL, or primary CNS lymphoma, is a mouthful, but I usually like to just say primary CNS lymphoma, is actually a lymphoma that is limited to the brain, the spine, the spinal fluid, or the eye, so the central nervous system, CNS. It is interesting because there is no real lymph structure like we know it from the rest of the body with a lymph node and other lymph organs that we can identify in the brain. So that was always fascinating to me. And it is actually a brain tumor, a malignant brain tumor that we can treat, and we can see some responses to therapy. So that's why I also got very interested because, we can be fairly aggressive in the treatment. It's also rewarding because we can reach very, very good outcomes with some of our patients.
What are possible causes and risk factors of this disease?
So there are two kind of groups of patients. So we have the immune suppressed patients, like organ donation recipients, or AIDS patients, or patients on immune suppression. They can develop a primary CNS lymphoma. But the majority of patients are elderly patients, immune competent, and these patients have primary CNS lymphoma. And we have a population that is getting older and older. And so we see a slight increase in the incidence of these tumors. And if I would be loving to be a little bit more specific about what's causing them, we haven't really figured this out in all the detail. So if there is exposure or other things, we can't really say for sure.
Not yet.
Correct. Not yet.
Not yet. We will be. I'm sure that we will be able to. My organization and I have worked with some PCNSL patients that are actually quite young.
Yep.
So you don't see that as much, but you do see it, right?
Yeah. Yes.
Right. Okay.
It is usually the general patient population is 60 and older. But you see primary CNS lymphoma patients that are younger. In general, the younger patients have a much better outcome because also they can tolerate more therapy, more intense therapy. And so, yes, but we see this disease more in the 5th to 6th decade of life.
Absolutely. And, I think it's something important for people to understand is that PCNSL I describe it as ultra rare. Is that correct?
Yeah, PCNSL is a rarer disease, so it's about 0.4 per 100,000 per year, so 30 people here in the New York area that have primary CNS lymphoma or develop a primary CNS lymphoma per year, and about 1,500 in the US. So that is not a very common disease compared to more common disease like glioblastoma or lymphoma outside the brain. So that is something that we see more frequently than what I see. Yeah.
So lymphoma out of the brain. We're still talking central nervous system, right?
No. I mean,
No. Oh, okay.
lymphoma, like diffuse large B-cell lymphomas of the body outside the central nervous system. Yeah.
I see. So if we were to say with this particular disease that in the United States, there's approximately 1,500 new cases a year. Do you know what the stats are as far as like how many people in the US are living with PCNSL? You know,
That actually depends where you receive your treatment. Because if you go to a specialized center, and there are many around, not just us, then there's more access to clinical trial, more advanced therapies, potentially with targeted agents. There's also more expertise in the management of side effects, in particular management of chemotherapy-related side effects. And the biggest culprit here is methotrexate. These patients all get methotrexate, and it can be very toxic to the kidneys. And if you have experience managing these complications, you have a better outcome. So, but we always state that about 80% of patients have a response. The big question is how long that response will maintain. But the rule of thumb is about 60% of patients are disease-free after 2 years of chemotherapy in a specialized center. The numbers are a little less promising when you look at the entire US population.
okay. I mean, honestly, that's promising, right?
Yep.
When you say 80% response and then we get to 60%, I mean, we both work in an area and a space where, we don't see that a lot with other brain cancer, right? So I feel like that's very good information and very good outcomes. We want it to be more always. So that's great. And, you just brought up a good point. You are treating patients, working at and doing your research at a specialty place for PCNSL patients. All right.
Yeah.
And so, yes, there is more expertise there. And yes, there are more clinical trials and more advanced diagnostics. All of those things make such a big difference in that ability to not only treat a patient and have, we hope, positive outcomes, but I feel like it also provides the ability for the patient, caregiver, care partner, family to have more hope with this disease. And I kind of think about that, and I always think about if possible, why would anyone not choose to be treated at a center that's known for whatever disease you have, known for its expertise. So that's one of the jobs that we do at the In Brain Cancer Initiative is we help people understand their options. And then we literally will help make those introductions for them to the specialists wherever they're at in the country based on their information, right? Based on their genomics or their biomarkers or all of those things. And there's a lot going on in that brain tumor space. It's pretty inspiring, really. But you got to sometimes seek out additional treatment options. Lots of times people have never heard of PCNSL. What can you tell us about common symptoms of this disease?
Common symptoms of PCNSL depend on where the tumor is located in the brain. They usually develop over weeks to months, so fairly fast, but also not too acute, and usually affect the deeper structures of the brain. So patients changing in their behaviors, they have memory issues, sometimes even weakness, gait difficulties, speech problems, but it's usually cognitive changes. There is sometimes a little bit of a delay because, these patients are elderly and then everyone approaches them and says, well, you're getting older, that's why you have symptoms. And there can be then a little bit of a delay before they get their imaging done. One part of lymphomas or PCNSL is also that patients can have ocular involvement first. And so the symptoms are then blurry vision or just other visual changes, and the original assessment by the eye doctors is more like, well, you have an inflammation, you get some eye drops, and then it just drags on before there is then an ultimate diagnosis, or people then develop brain involvement and have neurologic symptoms. So that can also happen. Sometimes also patients just don't know that they have the opportunity to get a second opinion. Especially nowadays, it's so much more. The world is getting smaller. You can get telemedicine visits, and so you don't really need to go to a big city if you can't afford to go to a big city, or if you're a little bit anxious of traveling to a big city, you can always try and do telemedicine visits and get a second opinion. I don't think that a second opinion hurts. The more opinion you get, sometimes the better. It, number one, confirms what you hear about your disease, what you hear about your treatment. You can then pick and choose what you like, who you like, and then sometimes a bigger hurdle is actually the insurance and insurance coverage for particular networks and hospitals. But that also can be overcome if you enroll into a clinical trial that is only offered in a particular center. So there are ways of getting more information and education from different physicians about your disease.
Absolutely. We want everyone to get a second opinion. And, a second opinion can also be like a third opinion, right? But at the very, very least, I almost don't care what you're diagnosed with, frankly, get a second opinion from someone who is considered a specialist in whatever disease you've been diagnosed with. Question for you, Dr. Grommes, is do you do telehealth second opinions?
Yeah, I do telehealth second opinion. The problem sometimes is that you have to hold a license in the state where the patient is located.
Yes.
And so that sometimes limits the abilities of telemedicine visits that we can do. But many states also now offer just telemedicine licenses. So the outreach is getting further. Most of the disease specialists do have telemedicine visit opportunities.
Okay. So you're in New York. I want to be really specific, if I could, on the telemedicine because it is so important. I don't know for you, and I do understand the licensing. I understand all of that, right? For you, are you saying that you can provide a telemedicine consult or second opinion for New York residents only?
Oh, I have multiple licenses. So because of my background and my training, I have a few more states in my pocket.
Are you able to share those states?
Sure. Yeah, well, I have no problems with sharing these states, but it's Ohio, Pennsylvania, New Jersey, New York, and Virginia, actually.
Thank you so much, because that's incredibly helpful information.
Mm-hmm.
So thank you for having licenses in those states, so that you can offer your expertise to others who live in those states. Thank you. When we put this video together for patient disease education, awareness, and outreach purposes, are we able to share your information? So when people see it, if they would like to have a consult with you or a second opinion, they know how to reach you?
Yeah, that's fine. We also do have record review options in case there is no telemedicine option available. But Again, there are some states where you don't need to have a license to still do telemedicine, but yeah, I would be happy to do that.
Can you explain for our audience what the record options means?
Yeah, so the patient sends in their records, their medical records, their images, the path reports, the lab results. We review them and then get back to the patient with an assessment, with a recommendation. Sometimes patients also like to ask some questions with that, and we answer those questions. And usually it's like a written report that they get back, and sometimes we also reach out with the phone, discuss a little bit what we recommend. And do like this kind of record review as a service, obviously, for patients.
That is fantastic. Thank you. I understand it's time consuming, but that is such a benefit to the general public. And particularly, we're talking about this particular patient population. But thank you for doing that. I also will say, if it's okay, our patient navigator with the End Brain Cancer Initiative is very helpful in helping people gather the necessary reports and helping them write their questions out so that they can provide everything in one beautiful package to you for a second opinion. So at the end of this video interview, we'll pop up our patient navigator's name and her contact information, and she's free to utilize her expertise to help all patients, all families, all caregivers, all care partners, all healthcare providers as well. So it's amazing. Okay. I'm so excited that we get to talk. So what happens, pretend if you would, maybe, that something's going on with me. I don't know what. I walk in and I get a PCNSL diagnosis. What happens next?
Yeah. So generally, these PCNSL diagnoses are established through a biopsy, sometimes a resection, so neurosurgical procedure after a lesion was found on the MRI scan. In some cases, also patients can get a diagnosis through a spinal tap or lumbar puncture when we collect the fluid that surrounds the brain and spine and we find malignant lymphoma cells. So that establishes the diagnosis, and then, it's all about treatment, and it's chemotherapy only. We try to avoid radiation because PCNSL is a very chemosensitive disease, and the main treatment, well, there is no gold standard that is defined, but we all in the field agree to use methotrexate. It's a methotrexate-based chemotherapy because we combine methotrexate with other agents, and the partners range from where you're trained, from the latest published data, to what you're comfortable using, and it's usually at least 3 drug combinations, unless you have some comorbidities or you're a frail person. Chemotherapy should not be limited to those with a good performance status, like we do in other brain tumors, because again, this is a very chemosensitive disease, and we have seen multiple times that patients that are really sick, if they respond immediately, well, not immediately, but tend to get better very quickly.
Is there a difference between a lesion on your brain and a brain tumor?
Depending, yeah. Some of the lesions in the brain are not necessarily malignant. There is a particular characteristics of these brain lesions that make them suspicious for a malignant process. And so then the question is it a malignant glioma, or it's a malignant lymphoma, or is it a benign lesion like a meningioma? Depending on where the lesion is in the brain or how it looks on the MRI scan, we kind of have an idea what it might be. But at the end of the day, there should be a biopsy to prove what kind of underlying disease it is, because there's wide differences in how we treat them.
Absolutely. That biopsy, not only is it helpful for pathology, right? But there's also some incredible information within that lesion or tumor tissue that is really important to identify to help treat, right?
Yeah. Also, maybe if I may say, the extent of surgery also depends a little bit on what we think the tumor is. Again, in lymphomas, we like to limit the surgical interventions because we can shrink the tumor with chemotherapy. in high-grade gliomas or other gliomas, we like to take as much out as possible. So there's a little bit of a difference. So that's also why when there is a neurosurgical procedure for a patient with a suspected malignant brain tumor, that there is a biopsy or a piece is taken, and within the surgical procedure, the pathologist looks at that and then guides if there is more surgery indicated or not, depending on the pathology. Again, we like to not that I'm a surgeon, but our neurosurgeons like to not resect lymphomas, because you resect also normal brain. And so the risk in PCNSL for permanent brain damage is basically, not from the entire surgery, but you can resect a brain that can lead to deficits that don't go away. And we can potentially avoid that by just taking a biopsy and treating the tumor with chemotherapy, which is different than what you usually experience with gliomas.
Right. Absolutely. You used a word, and I'm not sure all of our audience will know the meaning of it. So if you can explain it, that would be amazing. Comorbidity.
Yeah. So comorbidity means what other diseases or what other medication or what other factors affecting the patient's functional status. So the more diseases a patient has, like diabetes, hypertension, high cholesterol, prior heart attacks, coronary artery disease, the harder it gets to treat those patients, particularly because our chemotherapy with methotrexate requires a lot of IV hydration. And so patients with prior cardiac problems have sometimes difficulties managing through the therapy. So that's what I meant with comorbidities.
Thank you so very much. Okay, so you mentioned where you practice, MSK, is a center with PCNSL expertise.
Mm-hmm.
How do other people, find these centers that have expertise in PCNSL?
Yeah, well, by talking to their physician and also, with organization like yours, to kind of get an idea where centers are. Sometimes also what we do is to work with the local oncologist to kind of reassure the patient that they're on the right track with the right treatment, assist with managing of adverse events that come up during chemotherapy. But nowadays also the world, as I said, is getting smaller. So there's a lot of information also on the internet. That's kind of the avenues how patients can get a little bit more information about their disease.
Fantastic. And I know that part of our patient navigation services will help others also identify and make a direct connection to the specialist within that center that for PCNSL expertise. So we just want our audience to know that as well. Okay, so we're going to wrap up our first session, which was what is PCNSL?